Good morning, everybody. One of the larger health issues really facing women is cardiac disease, that most women actually are going to die of cardiac complications. So it's one of the most important diseases which are out there facing women. And patients with MPNs have a higher risk of developing cardiovascular disease. So it's something that we want to intervene on the best that we can. And sadly, the amount of research really looking at how we best treat MPN patients to prevent cardiovascular disease is relatively lacking. There's a lot of information about drugs, about certain parameters as to how we should treat patients, but how we actually prevent cardiovascular disease, and if you have a cardiovascular issue arise, how we treat that isn't really entirely clear. And we'll go through this data and talk about it a little bit. So what causes cardiovascular disease? What is it? And it's anything that interferes with the heart's ability to pump blood, so problems with heart function. Anything which clogs arteries or veins so blood can't flow, and that would include high hematocrits, white blood cells, or platelets, which makes the blood more viscous or thicker and makes the cells that ride through the blood cells actually less distendable or more stiff. And anything which interferes with the ability of oxygen to diffuse from the lungs to the pulmonary veins. So thickened airways, blood clots in the lungs which clog the airways, anything which interferes with the diffusion of oxygen. And what exactly is a heart attack? When someone has a heart attack, what does that really mean? And what that really means is that the arteries which flow through the heart get clogged. And usually that's with a blood clot. And you can see in this picture, the blood clot is resting in this gooey yellow substance, which is really atherosclerotic disease, which is thickening of the arteries by plaques that make clots more prone to develop. Okay. So, which one are we at? Did I skip one? Okay, so there are mutations in genes which lead to the increased risk of thrombosis, and we've talked about that in the prior two talks. And that's those driver mutations, that we talked about, the JAK2, the CALR, and the MPL. But also, there are other mutations which can arise. And whenever there's a bunch of mutations together in a cell, we sort of describe that as clonal, which we've talked about before, but I'm going to kind of sort of keep sort of that conversation going so you can recognize that word. And mutations can exist in your MPN that can be like clonal populations of undetermined significance. So you can have mutations in some genes that are not driver mutations that are there that may be affecting your disease, but it also may end up affecting your cardiovascular risk. And it's important to know that you can have an MPN, which is something called a triple negative. So you actually don't have one of those driver mutations. You're not positive for JAK2, you're not positive for CALR, and you're not positive for MPL, but you have a myeloproliferative disease. And sometimes, and oftentimes in those situations, you're going to find one of these other mutations, which may be a clonal mutation really of an undetermined significance, but it has resulted in your case with a triple negative MPN. So that exists too. You can have a non-driver mutation associated MPN. The prevalence of mutations really is associated, unfortunately, with age. So the older we get, the more likely we are to develop one of these mutations. So we ride around pretty happily till we get to around the age of 40. And as you can see, when we get to 40 and 50, things start to rise a little bit, and they rise much more dramatically. as we get to 60, 70, and 80. So we start making these mutations, all sorts of mutations, where the significance may not be entirely clear, but it may impact your MPN and it may impact actually your cardiovascular risk. And this was a relatively interesting study looking at the association between coronary heart disease and early onset heart attacks among patients who have these CHIP genes, or these clonal cytopenias of uncertain significance. And you can see those big diamonds there are really are indicating sort of your hazard ratio, or your risk, essentially, of having early onset heart disease or heart attack. And you can see that they're kind of to the right of the dotted line, which is showing you that you're at higher risk. So having one of these genes puts you at higher risk of developing an early heart attack or coronary heart disease. And you can see this in a different way here, where you're looking at all these diamonds that are associated to the right of the dotted line, which is an increased hazard ratio of having a number of cardiac, or having cardiac issues if you have these genes. And you'll notice there's a number of genes which are associated sort of with this condition. Amongst them is JAK2, and you can see JAK2 has actually a very high association with early onset MI or heart attack or a coronary vascular disease. So JAK2 mutations in this particular paper were thought to be, of one of those genes of especially higher risk in developing a cardiac disease. There's also been an associated with calcification or the atherosclerotic plaques that develop in your coronary arteries with these types of genes. So your risk of developing atherosclerosis is much higher. So atherosclerosis is really the precursor, or it is the what we sort of think of defining coronary artery disease. And when you get a clot on one of those plaques, that's what causes for you a heart attack. And JAK2 mutations actually increase the risk of atherosclerotic clot progression. And how they do this, there are various scientific theories, but amongst the most prominent are that JAK2 mutations inhibit the ability for you to extrude cholesterol from these plaques so that you hold on to cholesterol in your atherosclerotic plaques. And there's also impairment of macrophage phagocytosis. So there are actually cells which should be sort of roaming throughout those plaques and eating up some of that plaque material. And that's not happening in patients who have JAK2 mutations. There are other theories which abound as to why that might happen in JAK2 positive patients, but those are amongst the most prominent. When you have these mutations, there's an increase in inflammation, and all of you who have myeloproliferative disease have symptoms really that are resulting from this sort of increased inflammatory neighborhood that you are living in. But those inflammatory cytokines that are part of your disease can also enhance atherosclerosis. And that chronic inflammation can support the clonal expansion of your white blood cells, your red blood cells, and your platelets, and further cause the release of other inflammatory markers, which result in premature or progressive atherosclerosis. So when you read about cytokines, you'll read about TNF-alpha, or you'll read about IL-1 or about IL-6. All of these types of inflammatory markers which are made by your myeloproliferative disease can enhance the development of atherosclerosis. And that can happen with any inflammatory disease that a person has. So, if you have rheumatoid arthritis, or you have lupus, or you have other diseases like that, anything that's particularly inflammatory can cause early atherosclerosis. So atherosclerosis is a major risk factor for a heart attack or for a stroke, and interventions are needed really to help you to mitigate the effects of atherosclerosis. But the real question is, where do we intervene in patients who have MPN? And we're actually not 100% sure that we should treat patients with MPNs the same way that we treat other patients who have atherosclerotic disease. So there are a lot of dysregulated pathways in the development of MPN-related clots, which are really also associated with the development of atherosclerosis, and are associated with inflammation. So you can see that there are many JAK2, certainly, and interruptions in the JAK2 pathway are one of the major mechanisms through which this occurs. But there are also other small, integrins, ECANs, there are cytokines, there's something called NETs. All of these things are targets or particularly involved in the development of these atherosclerotic plaques and the risk of thrombosis. What are the impacts of having higher platelets, for example? How does this impact the development of blood clots or the development of atherosclerotic disease? And there's really an equivocal role of increased platelets in JAK2 positive patients. So in CAL-RET, there's decreased platelet activation in comparison to people who have JAK2. So if you have ET and you're CAL-R positive, it may be that your doctor is less excited about intervening on the number that your platelet count happens to be than if you're JAK2 positive. There's no clear association between platelet count and thrombotic events, but platelets greater than 1.5 million are associated with hemorrhagic events, and that's usually associated with the development of a disease called acquired von Willebrand syndrome. So when your platelets are really high, it may be that your doctor is actually testing you for this acquired von Willebrand syndrome, which can lead to increased bleeding. We know that a higher white blood cell count can enhance thrombotic risk. And we also know that cytoreductive therapy to reduce a platelet count has been shown to prevent thrombotic and bleeding events. So even though a particular platelet count might not be associated with the development of thrombosis, we do know that white blood cell count is important, and we know that when we do intervene on the platelet count number, that we can help prevent both thrombotic and bleeding events. High red blood cells, as you have in PV, 25% of PV patients actually present with thrombosis at the time of diagnosis. And during follow-up, lethal and non-lethal thrombosis occurs in 10% and 5% of patients. As we learned in the previous slides, that the hematocrit of less than 45% is less prone to vascular events. So in PV patients, we try and keep the hematocrit less than 45% to prevent these vascular events. There's increased rigidity, so the red blood cells are less likely to deform themselves to become a different shape as they flow through the blood system. Less platelet activation when the hematocrit is less than 45%. And there's an overproduction of cytokines in patients with higher hematocrits, with more endothelial cell, which is the cells which line the blood vessels. Those are called endothelial cells. And those can activate and actually activate platelets and cause thrombosis. So that anytime we have a higher hematocrit, we can have issues with the deformation of red cells to get through the circulation with increased platelet activation and increased endothelial cell activation. So have we ever, directly tried to target inflammation in atherosclerosis, and how successful was that? And there was a study called the CANTOS study, which actually used an anti-inflammatory medication to try and impact atherosclerotic disease and coronary vascular events. And this was done in over 2,000 patients, and it was targeting inflammation with an antibody against an interleukin. And this study actually showed that the primary endpoint of the study, which was non-fatal heart attack, a stroke, or coronavascular death as endpoints, that those were improved with this anti-inflammatory approach. The problem was that people got infections, and that was a big problem, so that while they were successful in preventing cardiovascular death and cardiovascular events, their risk of infection was a lot higher. So this never really caught on as a therapy for preventing atherosclerotic disease. But it's an interesting study showing that that particular targeted event was very successful. So is there a way we can target inflammation without increasing the risk of infection? And we haven't really figured that out yet. Hypertension, in addition to inflammation and higher cholesterol, is a risk factor for arterial thrombosis in myeloproliferative diseases. And there were two studies which really looked at hypertension as a risk factor in MPN patients. The first study looked at ET patients on anagrelide, and they looked at microvascular and venous events, and they found that arterial thrombosis in particular was associated with elevated blood pressure. There was a second study of 403 MPN patients, mainly PV and ET patients, and the comorbidity was also thrombosis with hypertension, and it was arterial thrombosis. So a lot of patients are a little cavalier about the control of their blood pressure, and maybe a little cavalier about taking their blood pressure medications, because you're not really symptomatic from a high blood pressure. And that can happen in normal patients who are not MPN patients. But it looks like MPN patients, in particular, may be afflicted with arterial thrombosis in the situation of high blood pressure. But note, there are only 2 studies looking at this. So that there are not good studies really looking at MPN patients and the risk factors for cardiovascular disease and how they impact the development of thrombosis. So here we're looking at a couple of the other mutations that are common, that are amongst these CHIP mutations, such as DMNT3A and TET2. A lot of patients develop these mutations as time goes on with their MPN disease. And these also show that there are increased risks of the development of myocardial infarction or cardiovascular disease with these 2 mutations. So that in addition to the first study I showed you, this was a second study really looking at these 2 mutations in particular, and they were found to be associated with predicting both death and any sort of cardiac event. This looks at the inflammatory cytokines in that same group of patients. And the inflammatory cytokine levels are higher in patients who have DMT3A mutations as opposed to those that do not. So DMT3A sort of clonal mutations also have been found to impact the actual cardiac sort of fabric of the heart, where it induces cardiac fibrosis and activates fibroblasts, which help make fibrotic material. So this causes an unfavorable outcome in patients with the development, potentially, of heart failure in actually deforming the wall of the heart by making it more fibrotic and less distendable. TET2 mutations also have been found to be associated with this sort of risk of heart failure with a less distendable cardiac fabric that causes heart failure in patients. So that these sort of constellation of different mutations that can occur in MPN patients can be important to the development both of coronary vascular disease, but also heart failure. So affecting not just the vessels of the heart, but sort of the fabric that the heart is made of, which helps pump the blood through the heart. And all of these observations actually make an important roadmap for new research, really, in cardiovascular disease. There's no specific studies actually looking at how to manage cardiovascular risk factors when you have an MPN. What level of cholesterol is really safe for an MPN patient? Do we treat them the same way that we do normal patients? What level of hypertension is really acceptable in a patient who has an MPN? We really don't know the answers to those questions. And is there a way that we can interfere with how these CHIP mutations may influence cardiovascular outcome? Can we influence inflammation without causing increased infection? Is that going to be a method by which we can control MPN patients a little bit better? Would antifibrotic medications in patients who have CHIP mutations, would they actually help decrease the risk of developing fibrosis or heart failure in patients who have these diseases? So we really don't know very many good answers to the questions, and I think that we do have data sets like the MOST data set, which was created by Insight, where we could potentially take a look at some of these questions, but there needs to be, I think, more interest in how we actually care for MPN patients who have cardiac disease. What are the outcomes in MPN patients currently with cardiac complications who are getting conventional treatment that we give everybody else? So the outcomes of patients who have MPNs and a myocardial infarction, there was a study looking at about 1,600 patients and looking at hospital admissions using inpatient records and looking at MPN patients, where they found that when they presented to the emergency room, they had a lower risk of in-hospital death, but a higher risk of major bleeding with the common therapies that we give patients when they present with an MI. But over time, as they spent time in the hospital, MPN patients had an increased risk of death from a cardiovascular event. And their risk of bleeding was the same as it was when they came into the emergency room, which is higher than for the normal patient. And you can see a couple of graphs here. We're looking at sort of the temporal trends over the years here of in-hospital death or cardiac arrest for MPN patients, where in the years since 2006, there's actually been an increase in in-hospital death for MPN patients, and that major bleeding has been a problem for MPN patients overall since the study had started with conventional treatment that we use to treat MI. So why is it that there's been increased trend toward cardiovascular death in MPN patients? Is it because there's less intervention that's being done in MPN patients when they present? Or is it the new anticoagulants which we're using? Originally, warfarin was the anticoagulant that was most commonly used, but we now use a category of anticoagulants called DOACs now that those are commonly used. Is that actually impacting overall survival in MPN patients? We have no idea. So we need to look at the way we treat patients conventionally with MI and why it is that MPN patients seem not to have the same outcome. And the bleeding risk is also very, very high in MPN patients. Again, how can we modify the use of anticoagulants or learn how to use anticoagulant therapy in a way that we can decrease the risk in myeloproliferative disease patients? We need to look at these populations and figure out, is it the type of anticoagulation we're using? What is it that's causing this particular problem? And there was also a study looking at the predictors of increased risk of adverse cardiac outcome in patients with MPNs and atrial fibrillation, which is an abnormal type of heart rate that can occur, which is very, very fast. And this particular heart rate can cause in normal people the development of blood clots and can cause heart failure. But there was a single center retrospective study where the outcome was cardiac death or arterial thrombosis with a secondary outcome of bleeding. And they looked at 142 patients with a mix of myeloproliferative diseases with the composite outcome, where the composite outcome was relatively high of cardiac death, arterial thrombus, and bleeding of 39%, with 30% cardiac death, 34% arterial thrombus, and 48% of patients with bleeding. And myelofibrosis in particular was associated with an increased risk of having this composite outcome. And the traditional risk scoring systems, which are used for poor outcome with atrial fibrillation, were very poor predictors of poor outcome in MPN patients. So those scales that are normally used in emergency rooms or in hospitals to gauge the risk of dying from complications of atrial fibrillation didn't really work well in MPN patients. And this is another graph sort of looking at these composite outcomes and how patients with MPNs did less well than patients who did not have MPNs. And some observations from this study that it was an older cohort, the average age was 78. 18% had atrial fibrillation before their MPN diagnosis, but 80% of these patients were JAK2 mutated. And they were on anticoagulation, 69% of patients, and aspirin, 68% of patients. And patients were treated with a mix of ablation, anti-arrhythmic meds, and their injection fractions were generally in the normal range at about 63%. 82% of patients were on hydroxyurea, and 54% of patients were on ruxolitinib, which is really an immunosuppressive type of medication. And after follow-up at 49 months, the all-cause mortality in this population was pretty high at 48%. Cardiovascular death was 18%, arterial thrombus 25%, bleeding 30%, and another hospitalization for a cardiac problem was 34%. Myeloproliferative or myelofibrotic patients had a higher risk of all-cause mortality at 85% versus 40% in the normal population. And traditional scoring systems were much less effective at predicting outcome. So these scoring systems are not really relevant in patients who have MPNs. And we need better management parameters for patients with atrial fibrillation who have myeloproliferative diseases when they come particularly into the hospital. At Cornell, we did a study looking at the prevalence really of right ventricular dysfunction in patients with MPN and its relationship to a heart failure type of problem called pulmonary arterial hypertension. And this was a single institution study at Cornell, and these were NPN patients who had an echocardiogram really for any reason, but they were reevaluated looking for evidence of pulmonary arterial hypertension. There were 301 patients who participated, and 56% of those patients actually had echo-derived evidence of pulmonary hypertension. Patients in this cohort were more likely to describe dyspnea as a symptom of, which is shortness of breath, as a symptom of their MPN. And at a 2.2-year follow-up, all-cause mortality was 27%. And if their pulmonary hypertension grade was 1.9, it was associated with a higher risk of mortality. So at this single institution study at Cornell, we found in patients who had gotten an echocardiogram, mainly because they had had a symptom on their MPN SAF of dyspnea, a large proportion of them were found to have pulmonary hypertension. Interestingly, this paper was impossible to publish. It was interesting information with a large proportion of patients who had pulmonary hypertension, which was rejected from every single hematologic journal, which is out there, and it ended up being published in a relatively obscure cardiology echocardiogram journal, showing you that the overall interest really, in this particular question is not very high amongst people who are the editors of blood journals, looking at blood disease. So that I think these are really, really important studies, but it was really interesting going through the process of trying to publish this paper and of how little interest there was in actually a high proportion of patients having a pretty devastating cardiac finding on their echocardiogram randomly. And there are other studies to show that pulmonary hypertension is really associated with poor cardiovascular and hematologic outcome in patients with MPN and coronary vascular death. Again, this was a single institution study done by Gabriel Hobbs, 197 patients, 92% of patients with pulmonary hypertension, and all-cause mortality was 58%. And cardiovascular death, 35% in the pulmonary hypertension group versus 5% in patients, or 9% in patients who didn't have pulmonary hypertension. And that these patients who had pulmonary hypertension also had hematologic progression, 23% in the patients who had pulmonary hypertension versus 11% in patients who didn't. And that in overall, there was, there was a high rate of hematologic progression if you happen to have pulmonary hypertension. And these are graphs that are really showing that from this single institution study, that the incidence of all-cause death, of secondary myelofibrosis, of hematologic progression, and of cardiovascular death was really higher in patients who had pulmonary hypertension. So we're learning more and more about the association of myeloproliferative neoplasms with cardiovascular risk. We know now that there is a role of clonal hematopoiesis in the development of atherosclerosis, arterial thrombosis, and heart failure, and we're finding more and more molecular mechanisms that may be associated with this. We're noting mechanisms that are induced by increased inflammation, including increased serum viscosity or thickness of the blood, and endothelial cell dysfunction. And so targets that we may find in that inflammatory cascade, which may be there for medications that can intervene. We're noting the association not only of JAK2, but of TET2 and DMT3A with cardiac fibrosis. And we're in great need of some studies here. You know, we need some prospective studies on the relationship of the somatic mutations in aging blood cells to the development of cardiovascular disease. We don't really, we're finding here and there different unrelated pathways which may be caused by sort of the inflammatory cascade caused by these clonal hematopoietic cells, but we need more information and we need more targets. And we need a target which is more global than sort of isolated individual molecular targets. We need studies on what the optimal control of cardiac risk factors are in patients with MPN. What level of cholesterol, what level of blood pressure is really right for the MPN patient? Do we have to treat them more strictly than we do normal patients or less strictly? Or is it not really as important as we think it is? So we need studies really to look at that. We need prospective studies on the development of pulmonary arterial hypertension in MPN patients and the relationship between bone marrow findings potentially and the development of pulmonary arterial hypertension. And would early treatment of PV and ET decrease the risk of pulmonary hypertension? Would it decrease the risk of MI? Should we think about treating patients more aggressively, more early on in their disease, particularly if they're younger? And what is the role of immunosuppressive medication in the treatment of MPN patients to prevent vascular disease and death? And do we find that there's an improvement in patients who are on ruxolitinib, for example, which is an immunosuppressive medication, in their risk of developing atherosclerosis or heart failure? And you know, hopefully some of the INSIGHT data sets will be used to look at that question. And is there a role for antifibrotic medications in MPNs with DMT3A chip mutations like TAT2? Would it help prevent cardiac fibrosis as well as progression of their MPN? So there's a lot of room for research in cardiovascular disease and myeloproliferative diseases. As I've alluded to, not so sexy that the hematologic journals are jumping up and down to publish these papers. But in day-to-day practice for your physicians, having that information would be really, really, really helpful. And it would help you to prevent cardiac complications of your disease, which is the #1 killer of women in this country. So I'd like to thank you for your attention, and I would really like to thank my team at Cornell, Dr. Robos, who you're going to hear from next, but also Pinkel Desai, Mike Samuel, Dr. Barnatan, Dr. Scandura, and Dr. Abuzena, as we all treat MPN patients and are looking for the best way to prevent poor outcomes. Thank you.